Good evening all. Hrct interpretation video continues. There will be areas of high attenuation and low attenuation. Firstly, high attenuation. Increased lung attenuation refers to opacification of Hrct image that can either obscure underlying vessels that in case of consolidations are present without obscuration as in so-called GGOs. Both findings can be associated with active or reversible lung disease. Though in cases with predominant fibrosis, GGOs can be seen more often. There is substantial overlap between the diagnosis of ground glass opacity and consolidation, and a differential diagnosis should be based on symptom duration or acute or versus chronic disease respectively. Ground glass opacities. Ground glass opacities does not obscure underlying vasculature and can be caused by various abnormalities like airspace disease, interstitial disease, or a combination of these two. Firstly, airspace disease, filling of the alveolar spaces with either pus, edema, or hemorrhage, or inflammation, or tumor cells. And interstitial lung disease, thickening of the interstitium or alveolar walls below the spatial resolution of Hrct as seen in fibrosis, or a combination of airspace disease and interstitial lung disease. These opacities are non-specific and can also be due to limitations of Hrct resolution. Then comes consolidation. The term consolidation refers to the presence of opacification that obscures the underlying vasculature. It is synonymous with airspace disease and implies that the air is replaced by either blood or pus or edema or cells. It can also be caused by fibrotic changes. Special consideration of the distribution of consolidation is important for a successful differential diagnosis. Underlying causes for peripheral or subpleural distribution can be cryptogenic organizing pneumonia, chronic eosinophilic pneumonia, atypical pulmonary edema, Churg-Strauss syndrome, drug reactions, pulmonary contusion, pulmonary infarct, or sarcoidosis. This is the picture showing ground glass opacity and consolidation. In consolidation, it obscures the underlying vasculature, whereas ground glass opacity won't obscure the underlying vasculature. That's the major difference between ground glass opacity and consolidation. Next, areas of low attenuation. Abnormally low attenuation on Hrct can be caused by emphysema, cystic diseases like lymphangioliomyomatosis, lymphoid interstitial pneumonia, Langerhans cell histiocytosis, bronchiectasis, honeycombing. This is the picture showing traction bronchiectasis, honeycombing, centrilobular emphysema, lung cyst, signet ring sign, TC, vascularity and blood vessel along with the airway resembling the appearance of signet ring. It is seen in bronchiectasis. Next, emphysema. Emphysema describes an abnormal irreversible enlargement of the distal air spaces which is accompanied by destruction of their parenchymal walls resulting in areas of low attenuation on Hrct. Classification of emphysema: centrilobular, panlobular, paraseptal. Centrilobular is predominantly seen in upper lobe, centrilobular origin portion of the lobule. Panlobular, predominantly seen in lower lobe, diffuse distribution, and it affects the whole secondary pulmonary lobule. Paraseptal, predominantly seen in upper lobe, subpleural in distribution, subpleural and interlobar, can resemble honeycomb changes. Differences between bronchiectasis and cystic disease. Bronchiectasis is defined as abnormal irreversible bronchial dilatation. It is often a result of prior infections, chronic bronchitis, COPD, asthma, and cystic fibrosis. To distinguish the various causes of bronchiectasis, a combination of the following additional findings should be considered: signet ring sign reflecting bronchial dilatation, bronchial wall thickening, lack of tapering, mucus retention in the bronchial lumen, air trapping. Bronchiectasis must be discriminated from traction bronchiectasis, which is a result of fibrosis. Cystic diseases. Pulmonary cysts present as circumscribed and radiolucent lesions with a thin wall, usually less than 3 mm thick. They are often caused by fibrotic changes, resulting in honeycombing. These cysts can have a diameter ranging from several millimeters to several centimeters. Adjacent cysts share the wall, a finding not seen in other cystic lung diseases. Examples are lymphangioliomyomatosis, Langerhans cell histiocytosis, lymphocytic interstitial pneumonia, and nematoses. Recognition of idiopathic interstitial pneumonia pattern on HRCT. UIP pattern. In UIP, in HRCT we see reticular opacities, honeycombing, traction bronchiectasis, focal ground glass opacities, and their distribution on CT. UIP will be predominantly peripheral, subpleural, basal, and in lower lung zones, and there will be apico-basal gradient. From apex, as you go down, there will be increase in the HRCT features like honeycombing, traction bronchiectasis, GGOs, reticular opacities, etc. NSIP, non-specific interstitial pneumonia. HRCT features are ground glass opacities, irregular linear or reticular opacities, micronodules, consolidation, microcystic honeycombing. Distribution will be peripheral. Cryptogenic organizing pneumonia, airspace consolidation, mild bronchial dilatation, ground glass opacity, large nodules, which will be rare. Cryptogenic organizing pneumonia distribution will be peripheral and peribronchial. RPILD. It will be central lobular nodules, patchy GGOs, bronchial wall thickening. Distribution will be diffuse or upper lung predominance. DIP, desquamative interstitial pneumonia, GGOs, irregular linear or reticular opacities, occasionally cis. DIP distribution will be lower lung zones and peripheral predominance. LIP, lymphoid interstitial pneumonia, ground glass opacities, perivascular cis, septal thickening, central lobular nodules. Distribution on CT, basilar predominance or diffuse. Acute interstitial pneumonia, exudative phase shows ground glass opacities, airspace consolidation. Organizing phase shows bronchial dilatation and architectural distortion. Distribution will be diffuse. Idiopathic interstitial pneumonias are defined as an entity of ILDs of unknown cause. They can be classified based on characteristic HRCT features that are associated with certain histological patterns. These HRCT patterns are unique for each of the entities. Diagnosis of ILDs of unknown cause, UAP, usual interstitial pneumonia. It describes the typical histological and CT patterns occurring in IPF. This pattern is required for the diagnosis of IPF when other known causes or features inconsistent with UAP can be ruled out. The most predominant UAP features to be found are reticular changes like honeycombing, traction bronchiectasis, with the disease being most extensive in the lower lobes of the lung and having a peripheral distribution. Although honeycombing in HRCT is of paramount for diagnosis, identification of this feature can be challenged through frequent disagreement among radiologists on their findings. Other conditions can also mimic honeycombing like emphysema or traction bronchiectasis. Distribution and CT pattern of UAP. Here the distribution is subpleural and apico-basal. From apex, as you go down, there will be increase in the features like reticular opacities, traction bronchiectasis, etc. Here CT shows honeycombing, round-like structures, reticular opacities, thread-like structures, this is reticular opacities, traction bronchiectasis, cylindrical shape, and ground glass opacities. HRCT pattern for UAP. UAP, possible UAP, inconsistent with UAP. Firstly, UAP, all four features will be present. Subpleural, basal predominance, reticular abnormalities, honeycombing with or without traction bronchiectasis, absence of features listed as inconsistent with UAP. Possible UAP, all three features should be there. Subpleural, basal predominance, reticular abnormalities, and absence of features listed in inconsistent with UAP. Inconsistent with UAP, any of the 7 features: upper or mid lung predominance, peribronchovascular predominance, extensive ground glass abnormalities, profuse micronodules, discrete cis, multiple bilateral away from areas of honeycombing, diffuse mosaic attenuation and or air trapping, consolidation in bronchopulmonary segments. Let's meet in the another video.